This is caring for the special needs child. So let's start by defining what that is. It's defined as those who have or are at risk for a chronic physical, developmental, behavioral, or emotional condition beyond needs generally required by children. So this is going to include kids with a lot of medical needs, medically fragile children, or medically complex, even if they're not very fragile, and then children who are dying. So children with special needs need special resources and services for them and for the family. They usually are on a lot of medications. They usually need some durable medical equipment, and you'll hear this called DME. This is things like wheelchairs, walkers, special car seats that they can fit in if they don't fit in a regular one. They need medical care by providers, including the ability to get to and from those appointments. They usually need mental health and educational services, therapies, physical, occupational, or speech therapy, treatment for emotional, developmental, or behavioral problems, financial assistance. This can be very expensive, and a parent may need to quit work in order to provide care for the child, so that further complicates the financial situation. And then the family needs support. They're trying to do something that's really hard. Raising children is hard. Those of you with children know that. Raising a child with special needs is harder. People would say it's worth it, but it's hard. Kids with special needs, they want to do the same things that other kids do. I think this is going to a ball game. So the impact of special needs on the child, it can prevent them from meeting those developmental stages. So for the infant, can they develop that sense of trust and bonding with the parent? If they're in the hospital and they can't be touched, how are their needs going to be met to develop that trust? For the toddler, if they never can do anything on their own, dress themselves, put their shoes on backwards, those things that toddlers do, they physically aren't allowed or able to, how do they develop a sense of autonomy? For the preschooler, how do they develop that initiative, that stepping out and trying things on their own if they're not able to? For the school-age child, these kids love all the activities that they do. They love that achieving industry. Well, if they can't do crafts and piano lessons and those things, how do they achieve that? For adolescents, it's developing that self-identity. Well, when you need somebody dressing you and bathing you, how do you figure out who you are when you can't even care for yourself? So it's very hard for these children to meet their developmental stages. And has a huge impact on the family. Family usually goes through all sorts of emotional changes. It can be very overwhelming. Parenting in general has moments of being overwhelming, but when you increase the level of care and it never stops, that gets really overwhelming. Parents often experience fear, anger, sadness, guilt, frustration, resentment, and they can flip-flop back and forth between those. Doesn't mean we're going to let a parent yell at us, but realize when they've just been given a diagnosis that rocked their world and they yell at you, okay, they're not really angry at you. They're angry at everything that's going on right now. It's okay to say, you can't yell at me. I'll come back when, you're feeling like you can have a conversation. That's okay. But don't be overly hurt by it. Think how you would be feeling if you had just been told your child will never recover from whatever is going on. Siblings. Gosh, the siblings, often they feel jealous or cheated. The parents are spending all their time at the hospital with that sick child. So they're angry and then feeling guilty that they're angry. And often they start acting out Financial burdens, again, a parent may have to leave work to care for the child, and that just adds to the financial problems. And every little thing can't be done the way you used to do it. You have to think about it. So housing, can they live where they were if they now have a wheelchair and a couple of steps or a whole, 2-story house? They've got to change things, or maybe even change where they live. This child may not sleep through the night, and if they have medical needs, you're getting up at night. So now people are not sleeping. Just carrying out those basic activities is going to be different. And they've got to learn a whole lot of medical and technical care. Family identity and employment can change. We used to be the family that went camping, and now we've got a child who we can't go anywhere where there's not electricity to plug in their equipment. And again, siblings can feel neglected, jealous, start acting out. So just those everyday things. Instead of being able to just let your kid walk to school, they've got to walk with crutches, which takes a lot more work. Or you've got to get up an hour early to do your breathing treatments before school. So transition times are going to increase that stress. So anytime something changes, including that initial diagnosis or a change in the prognosis, when symptoms increase, all of a sudden we've got to change what we're doing. That's going to increase stress. New settings. Child goes to a school where the kids don't know, the teachers don't know, the school nurse doesn't know, or they go to the hospital. That's stressful for everybody. Now they leave the hospital and they have to go back to school where they're weeks behind. That's stressful. For all these changes, think of them as, moments of increased stress. Parents' absence. Parents got to go back to work. Parents got to go on a business trip. Parents split up. The stress of a special needs child, unfortunately, often does damage to the parental relationship. Periods of developmental change. Those are awkward anyway, and add in the special needs. They're more awkward. Arrival of new family members, whether that's, and I'd say arrival or leaving, really, whether that's somebody being born, somebody moving into the household, somebody moving out of the household, all of that going to increase the stress. So something that can happen is this vulnerable child syndrome. This is where the parent treats the child differently, kind of overprotects them because they're the sickly child. They've had special needs, and so we continue to treat them as if they're very fragile when they no longer are. This happens often after a preterm birth, or if a child's born with congenital anomalies. Even after repair, they're often treated as if they still have to have special treatment. A baby who is treated for jaundice, any kind of handicapping condition, a child who had a bad accident, you didn't expect them to survive, but they did. The risk is the parents continue to kind of smother them, overprotect them. Or babies who had crying and feeding problems in the first 5 years of life are at risk of this overprotection, vulnerable child syndrome. So with our families, principles related to family involvement, remember the family is the constant in the child's life. You may be the best nurse, the best student nurse that child's ever had, but you leave. It's only the family that stays there. So the family really is the most important person in this child's life. That doesn't mean don't do a good job, but realize the family's more important than you are. The family defines who the child is. The family's the one that teaches them their culture. The family needs access to information, and this is our job, right? To make sure that they get the relevant information that they need and that we train them in the care of their child. Families deserve to receive culturally competent care. We are not going to tell them how to do things the way we want them done. We are going to teach them how to do things the way they want them done. Whatever those cultural differences might be from us. Families, they all have strengths, but they also have limitations and fears. We need to identify their strengths, build on those, identify their limitations, try and minimize those, identify their fears, and alleviate those. Families all merit mutual respect in the caregiving relationship. We are not the expert on their child. They are. We are the medical expert. We know how to do tube feedings or manage cystic fibrosis symptoms, whatever it is. Yes, we have that knowledge, but we're a team working together to get the best care possible and the best outcome possible for their child. So promoting home health care for the technologically dependent child. This is very complicated, and so discharge planning has to happen early. We've got to provide care, so making sure that we do have someone they can call, a home health agency they're connected with, as well as coordinating that care. We want to make sure that they're not going to 3 different doctors who are all doing different things. So providing care and coordinating care at home, identifying problems before they get to the home so that we can figure out ways to eliminate or at least minimize those problems. Make sure they're getting follow-up care and routine well care, that we're not forgetting that, especially with our former preterm infants. They do need follow-up care. And then if we had a preterm infant, we're going to assess their growth and development on their adjusted age. So not based on when they're born, based on when they would have been born. So if they're born early, 3 months early, we're going to take 3 months off of what they, the size they should be and the developmental skills they should be at. So here's how complicated things are. He wants to go out for the day, but he's on a ventilator. So you've got to bring spare trachs. You've got to bring suction, your little portable suction in case he has a problem with suction catheters. You've got to bring the ventilator he's on. Make sure the batteries are charged, right? You don't just hop in the car and go out. So long-term risks for our preterm babies, they are at risk to have cognitive delays, visual impairment, retinopathy of prematurity. That's one of the reasons that we try and get their oxygen down as early as we can, because it's excess oxygen that damages the retina. Chronic lung disease, cerebral palsy, attention deficit disorder, learning disabilities, difficulty with socialization, developing that vulnerable child syndrome where the parents overprotect them, alterations in muscle tone goes along with the cystic cerebral palsy. So those are all risks for those preterm infants. And failure to thrive. What causes failure to thrive? Well, it can be organic or inorganic. A problem with sucking and swallowing, so the baby just doesn't get enough in. There can be a problem where they're not absorbing, even though it is getting in. Perhaps the parent don't know how to mix baby formula properly. Kids who are having chronic diarrhea or vomiting, so they're losing those calories. Or they have something abnormal in their metabolism that makes their caloric needs higher, and they're having trouble meeting that. We do find failure to thrive where there's disrupted relationship with the maternal figure as well. So kids with special needs, they need special resources. That includes education, finances for the family, for their supplies, their meds, all those things. Respite care, you can't just call the teenager down the street. You've got to get somebody trained to give you some time away. And then complementary therapies. There are some things that we just can't fix, and letting families try other things often is helpful, or at least let them try. Don't tell them that they can't.